This is a short presentation introducing immunomodulators. To determine which medications are monoclonal antibodies, they all end in MABS. You notice here in this list that the suffix is MABS. And a MAB, or a monoclonal antibody, is derived from a human, but sometimes it can be a combination of a mouse or similar rodent or by itself. An antigen is introduced into a host, and the host makes antibodies to the antigen, and we know this from pathophysiology. The cells with antibodies will be combined with tumor cells, and what we're trying to form is hybrinomas. These hybrinomas will divide and they don't restrict. And once they divide, they make enough copies that at this time antibodies can be isolated to make a drug against that type of tumor cell. Monoclonal antibodies work at the site of the cell membrane, receptors, and they can target specific antigens. Just like antibodies, our monoclonal antibodies activate our natural immune response, and we have many uses in healthcare. We treat cancer. You can see here there's a list of monoclonal antibodies that treat asthma, infectious disease, migraines, hemophilia. Now, the drugs that are outlined in the chapter of your book also include the newer drugs for the treatment of asthma and C. diff, as well as migraine prevention, which you can see Immunomodulators is a monoclonal antibody for migraine prevention. The monoclonal antibodies for the treatment of cancer and rheumatoid arthritis, these were somewhat discussed in the chapter with rheumatoid arthritis, and we're going to talk about it in terms of the treatment of cancer this week. You can see here a schematic representation of how monoclonal antibodies are produced. And again, the antigen is injected into the mouse or host. We wait for the antibody to be produced on the plasma cell. It gets fused together with the tumor cell, becoming a hybrinoma. And once the hybrinoma is formed, we can pull out of that the desired antibody. Now we have an endless supply of monoclonal antibodies to fight different disease processes. The monoclonal antibodies for asthma are listed here, and you can see the drug omalizumab was also discussed when we went over asthma. This was the first monoclonal antibody approved for allergy-related type asthmas. And remember, asthma itself is a disease process that involves immunoglobulin E, or IgE. So this drug works by combining with free IgE, and it reduces the available IgE that binds to receptors on the surface of mast cells. And if we can do this, we decrease mast cell activation, which will decrease airway bronchospasms, inflammation, and the allergy-related type asthma symptoms. The other drugs that you see listed here, mepolizumab, benralizumab, and reslizumab, are approved for eosinophilic type asthmas. And the way they work is that they're actually going to bind to interleukin 5, which is responsible for functioning of eosinophils and the survival of eosinophils. Remembering that eosinophil activation promotes airway inflammation, bronchial hyperactivity, and when these three drugs bind to interleukin 5, it's unable to react with the receptors on the surface of the eosinophils, and then it will decrease the production and the survival of the eosinophils, reducing asthma-type symptoms. The last one is also a drug that treats eosinophilic type asthmas, and this one is called dupilumab. It differs though because it, instead of targeting interleukin 5, it's targeting interleukin 4. And by targeting interleukin 4, both type 1 and type 2 receptors on the mast cells and the eosinophils, we can reduce allergic inflammation. It's also going to work on interleukin 13. And again, this is going to cause inhibition of eosinophil apoptosis, induction of eosinophil chemotaxis, and all of this will be hindered, meaning that asthma that's triggered by eosinophils will be stopped when using this medication. In terms of monoclonal antibodies that are used for infectious disease and migraine, these are the two drugs that we have here. Bezlotuzumab, this is used for patients that are undergoing current antimicrobial treatment for C. diff, but they're at very high risk for reoccurrence. And so by giving them a monoclonal antibody, we're hoping to reduce that risk. The human-derived antibody is going to bind to C. diff toxin B, and it's going to reduce the reoccurrence. This medication lacks antimicrobial properties, so it can't treat C. diff. It has to be used with another antibiotic that actually will work on C. diff itself. Monoclonal antibodies like Immunomodulators can be used for migraine headaches. It is the first FDA-approved monoclonal antibody for the prevention of migraine headaches. The way it works is it's thought to work on the calcitonin gene-related peptide, or CGRP, which plays a role in promoting migraine headaches because it will cause vasodilation and the release of inflammatory neuropeptides. So plasma levels of calcitonin gene-related peptide are going to actually rise up during a full-blown migraine attack. What this drug does is it's going to block the receptors of calcitonin gene-related peptides so your body can't take that up, therefore deterring a migraine attack. It's interesting that this drug isn't derived from human antibodies. It's actually produced with Chinese hamster ovary cells, and it's administered to patients sub-Q. In clinical trials, it was shown to be effective in both episodic and chronic migraines, but right now FDA approval is only for preventative migraine headaches. You can see here on this chart the monoclonal antibody name, trade name, and what it's targeting. The adverse reactions we're going to talk about are for monoclonal antibodies in general and not for a specific monoclonal antibody. And because immunomodulators will boost your patient's immune system, we have to think about immunogenicity, which is the development of adverse immune reactions. These reactions always occur secondary to the production of anti-drug antibodies, or ADAs. These ADAs cause inactivation of the drug and can cause serious effects for patients, including anaphylaxis. So what type of characteristics will increase the risk for immunogenicity? Prior exposure to a similar protein-derived drug, the route of administration, the dose and frequency of administration can increase that risk of immunogenicity. You should know that IV administration has been associated with a decreased risk of sensitization. We also know that if the drug is developed from a non-human source, then there's going to be a higher immune response likely. In terms of anaphylaxis, we know that the production of anti-drug antibodies leads to anaphylaxis when there are specific immunomodulators administered to your patient. And although the presence of these antibodies don't necessarily indicate anaphylaxis, it can occur. In addition to anaphylaxis, you have to look out for cytokine release syndrome, or CRS. And this is when pro-inflammatory cytokines are released. It's usually going to be released from leukocytes, and the key cytokines you're looking for are primarily interleukin 6, but it can also include interleukin 1 and interleukin 2. The common signs and symptoms that are associated with CRS that I want you to know are fever, nausea, vomiting, diarrhea, and rash. Although you should also realize that with serious cytokine release syndrome, your patient can present with hypotension, tachycardia, tachypnea, delirium, and seizure as well. If this happens, our management for our patient is largely supportive. We can give a monoclonal antibody then that fights against interleukin 6, and this is called tocilizumab. For the non-acute reactions, like, for instance, a delayed hypersensitivity reaction, that would include fever, rash, hemolytic anemia, hematuria, myalgias, and arthralgias, we're still going to do the same thing. It's just supportive care. But in severe cases, you can also elect to give your patient a corticosteroid as well. There are some monoclonal antibodies associated with organ toxicity. I've listed them here for you to look at. In terms of dermatologic type toxicities, if this happens, you want to put a topical or systemic corticosteroid to help reduce the symptoms of itchiness, dry skin. You might also give a topical or oral antibiotic, because this itchiness and dry skin can actually lead to a Staphylococcus aureus type infection or herpes simplex type infection. But why do they get this infection in the first place? Well, with many of the monoclonal antibodies, they target epidermal growth factor receptors. These receptors are expressed in skin epithelial cells, and they regulate the differentiation and migration of your keratinocytes at the skin surface. Well, this blockade of epidermal growth factor receptors, or EGFRs, will lead to skin fissures. It might lead to an acne type rash, pruritus, and cirrhosis, which is very dry skin. And with patients that can't handle these symptoms, they usually are scratching a lot, the dry skin can open up, and then there's that secondary infection by herpes or Staphylococcus aureus. There might even be some GI toxicities that are associated to a couple of the monoclonal antibodies. You can see them listed here. And what you'll see is diarrhea, which is very common in about 50% of these patients that take these drugs. Severe colitis can also be seen in about 8% of these patients. What you would do is tell them to stop taking the drug, and you might have to give them a glucocorticoid to reduce the inflammation. Hepatotoxicity has also been seen with some monoclonal antibodies, and usually what you're going to notice is an elevation up to 5 times the normal liver enzyme level about 6 weeks after therapy. And the drug-induced liver damage is occurring as a result of the immune-mediated hepatocyte necrosis and damage to the biliary tree. It's also of more concern if there is a concomitant rise in your bilirubin levels as well. And so what you would do is stop the medication and watch for severe liver injury, which is uncommon, yet we have noticed from studies and previous exposures to these drugs that death can occur. There are other inhibitors as well. In addition to the monoclonal antibodies, we have tyrosine kinase inhibitors, and sometimes they're called NIBS. And these inhibitors will work intracellularly by blocking tyrosine kinases that send growth signals. If your cell can't send a growth signal, it can't grow and it can't divide. And this is especially helpful when you're trying to keep cancer at bay. Now, NIBS are synthetically created in labs, and they're available in oral forms. Currently, the tyrosine kinase inhibitors that we have are used to treat hepatocellular carcinomas, We also have some that will treat thyroid cancer, renal cell carcinomas, metastatic melanoma, and other types of malignancies as well. There are about 30 tyrosine kinase inhibitors, or NIBS, and you can see them listed in your textbook. In terms of the toxicities that can occur when you're using tyrosine kinase inhibitors, the common ones are dermatologic. They also will target the EGFR. And the mechanism for dermatologic toxicity is just the same as we talked about with the monoclonal antibodies. And so if this happens, you'll tell them to stop the drug as well, and you would try to treat if they have a concomitant infection. GI toxicities also occur that can result in diarrhea, stomatitis, and it appears to be a higher risk for those patients that are receiving chemotherapy. But it's working on the EGFR that are highly expressed on the epithelial cells of the GI tract. And most likely it's related to having too much chloride secretion, your motility is dysfunctional, and there's inflammation that occurs when the blockade of EGFR is realized. And the most common side effect is going to be that diarrhea. So when this happens, it's largely supportive care that we're aiming for. We might have to give loperamide for the diarrhea rehydration therapy, and potentially you might have to use antibiotics if your patient has a secondary fever. The last set of inhibitors we're going to look at are called proteasome inhibitors, and sometimes they're called MIBS. And they're kind of like the tyrosine kinase inhibitors in where they work intercellularly. The proteasomes break down unused and unwanted proteins that are in the cell. And if you block the proteasomes, then unwanted protein buildup eventually will cause cell death. The MIBS are used to kill cancer cells, and proteasome inhibitors are used to treat multiple myeloma, mantle cell lymphomas, and it's really important to understand that MIBS are substrates of the cytochrome P450 enzyme, and so they can cause more medication interactions than the other types of immunotherapies that we talked about. In terms of toxicities, it's largely cardiac and GI that you are worried about. And although cardiac is rare, you can see serious adverse effects from these proteasome inhibitors. Most commonly, you're going to see heart failure and arrhythmias. We don't really understand what the mechanism of cardiotoxicity is when using proteasome inhibitors. However, it is related to endothelial dysfunction and inflammation. GI side effects are also common. Frequently, you'll hear patients complain of nausea, vomiting, diarrhea, and constipation. In severe toxicity, they may even have colitis. Colonic ulcerations have also occurred. And obviously, you're going to stop the medication if that is the case. The mechanism behind these side effects is also not fully understood, but potentially it's related to the pro-inflammatory cytokine secretions. The patients that are going to be most at risk for getting a GI type toxicity are the older patients, those that are also on chemotherapy, or they've had some type of history of irritable bowel syndrome, diverticulitis, or colitis. Those patients that are on radiation therapy are also more at risk for these type of GI toxicities, and you can see the drugs that are more commonly going to cause GI toxicities. For more information, go to the charts in your textbook.